Good afternoon, good evening, good morning, wherever you are. Welcome. My name is Sandro Galea. I have the privilege of serving as Dean of the Boston University School of Public Health. On behalf of our school, welcome to this public health conversation. These conversations are meant as spaces where we can come together to discuss issues of consequence for health. A healthier world is downstream of the public conversation about health. Through a process of discussion and debate, we aim to elevate the ideas that get us to such a world. Thank you for joining us, for being part of today's conversation. In particular, thank you to Dr. Sarah Lipson, the intellectual architect of today's event, and thank you to the Dean's Office and Communications team, without whose efforts these conversations would not take place. Today, we're here to discuss initiatives particularly close to home for an academic community. Supporting the mental health of college students is core to our mission of creating a space where all our students can learn and thrive. This work can also help us to better engage with public health's effort to support mental health more broadly, in a moment when mental health has been challenged by factors like the isolation of the pandemic, effects of new technologies. I look forward to learning from all our speakers today as we continue our engagement with this issue. I'm now delighted to introduce our moderator, Kate Hidalgo Bellows. Kate is staff reporter at the Chronicle of Higher Education, covering health and safety on campus. Since starting at the Chronicle as a fellow in 2021, she has reported on student protests against sexual assault, campus suicide clusters, the growth of teletherapy on campus, and parent groups' attempts to get institutions to increase their security measures. She led the Chronicle's daily briefing newsletter from 2022 to 2023. We're delighted to have Kate joining us. Kate, thank you. Over to you.
Thank you so much for that introduction. It's my pleasure to be moderating today's public health discussion. I'll now introduce our speakers for this program. First, we'll hear from Khadija Booth Watkins, Associate Director of the Child and Adolescent Psychiatry Residency Training Program of Massachusetts General Hospital and McLean Hospital. Dr. Booth Watkins also serves as Associate Director of the Clay Center for Young Healthy Minds, Associate Director of the Psychiatry Clerkship at Harvard Medical School, and instructor at Harvard Medical School. She specializes in the evaluation, diagnosis, and treatment of psychiatric disorders in children, adolescents, and adults. Her areas of particular interest and expertise are anxiety disorders, attention deficit and hyperactivity disorder, student and college mental health within schools, diversity, inclusion, and suicide prevention. Next, we will turn to Jason Campbell Foster, who serves as Boston University's Dean of Students. Dean Campbell Foster works to deliver a world-class experience for students where they are able to thrive and reach their full potential. Prior to his current role, Dr. Campbell Foster served as BU's Senior Associate Dean of Students, and prior to BU, he held a variety of leadership roles at Northeastern University. Then we'll hear from Brett E. Schofield, who currently serves as the Associate Director of Penn State Center for Counseling and Psychological Services, as well as their Executive Director of the Center for Collegiate Mental Health, a national practice-based research network of over 775 college counseling centers. Dr. Schofield has played a significant role within CCMH for the past 9 years, contributing to several publications on the topic of college student mental health, and helping the center develop numerous tools that are widely used by college counseling centers nationally to advocate for services. Finally, we will hear from Sasha Zhou, Assistant Professor in the Department of Public Health at Wayne State University, College of Liberal Arts and Sciences. Dr. Zhou's research uses mixed methods to understand and address the mental health needs of emerging adults and college student populations, with a particular focus on underserved populations, including students of color, international students, and sexual and gender minorities. Dr. Zhou is also co-investigator of the Healthy Minds Network, a research to practice network dedicated to improving the mental and emotional well-being of young people through innovative multidisciplinary scholarship. So first, Dr. Booth Watkins will present. So Dr. Booth Watkins, over to you.
Thank you so much for having me here today. I'm going to share my slides, but I'm feeling very grateful to be able to have the opportunity to have this conversation with you all. And so I do not have, okay. I don't have any disclosures. I wish I did, but I don't. And I would just jump right into the statistics. We are in the middle of a mental health crisis as it relates to our young people. And, this has been going on for the past couple of years. as it relates to our young adults who were, for many, were just in that bracket that includes young people, they're struggling as well. And so just a couple of statistics as to where we are. Young people between the ages of 18 and 25, 1 in 3 experience mental illness, 1 in 10 experience serious mental illness. But what's also concerning is that 67% with depression and anxiety don't seek treatment. Suicide is the second leading cause of death for our young people between the ages of 10 and 24. And really that number, I think, goes to 34. And with respect to suicide, there's great disparity, with suicide rates growing the fastest among our Black youths. And so there's no surprise then as to why there's a crisis on campus. And if we know that 50% of mental illness presents by the age of 14, and then we also know that 75% of mental illness presents by the age of 26, we have an opportunity. We have we're uniquely positioned to be able to be proactive in thinking about how we can support young people, how we can identify challenges early and intervene earlier, because what we do know in all of medicine, early prevention and early intervention has the best outcomes. And so you mentioned the Healthy Mind Study. And so the Healthy Mind Study has done some surveys and came out with over 60% of college students meet the criteria for at least one mental health condition. 83% reported that their performance was negatively impacted by their mental health. And 2 out of 3 students reported struggling with loneliness and isolation. And we're going to come back to that because that is also a rising kind of epidemic that's happening with our young people as well. Another survey reported that 3/4 of students reported moderate or severe psychological distress. 44% reported depression, 37% anxiety, and 15% reported that they had seriously considered suicide. And again, these numbers are rising, and these are the highest numbers that have been seen in over the 15 years of the survey. And so just circling back to loneliness, the Surgeon General put out this advisory raising the alarm about the devastating impacts of loneliness on our young people. And he really, within this report, he likened it to smoking 15 cigarettes a day. And so we probably all know by now how harmful cigarettes are to our body. And so if we think about it and link those together, it really does drive home the impact of loneliness. But specifically, some consequences of loneliness and feeling isolated are, there's emotional fallout, there's disruption in sleep, we struggle, and it's much harder to regulate our emotions. And then we can also have medical problems because of being lonely. We are kind of just the way we're built and wired. We're pack animals. We're not meant to be alone and to be isolated. And so loneliness can have tremendous impacts on young people. Our young people are stressed out. And so if we think about why they're stressed out, specifically, I just kind of put them in these kind of boxes to help us kind of tease out what is stressing out our young people and our young adults, and specifically the pressures of school. So whether it's academic pressures, there's some young people that are engaged in community service or really engaged in advocacy, can be stressful. Student athletes trying to balance, their athletic performance with their academic performance can be stressful. We know that some kids struggle more with social engagement, being social, and then some people struggle with socializing too much. And again, really, it goes back to striking this balance. Some young people have to work while they're in school. Some people are stressed about the finances. How are they going to pay for their tuition? How are they going to repay their loans? And then there might be things going on with people personally and within their families. And some people still do have family obligations, even though they're in college. A lot has been said about the impacts of social media, so I won't go into that too much. But another big stressor for students is that they're worried about their future. They're worried about what's the job market going to look like for them? What's the economy going to look like? What's the world going to look like, from climate change to the safety of the world around us in terms of, mass shootings and war and so on and so forth. Students tend to be overscheduled. This tends to happen prior to college, and it kind of continues when they get to college. And when you're overscheduled, you struggle with sleeping because you're staying up late trying to get things done. We tend to eat more poorly when we're overscheduled. Our exercise, habits fall by the wayside. But also, if we think about, again, going back to loneliness, if we're so overscheduled, it's really hard to really find time to engage meaningfully with our peers and other people who are important to us. And so our connections really fall short too when we're overscheduled. But the list really is endless in terms of the things that young people are struggling with and are stressed out about. And similar to loneliness, because loneliness is stressful, there are unhealthy consequences to stress. Again, our sleep, it gets impacted. We start to have trouble with our relationships. maybe because we're short-tempered, or maybe because we are not our usual self because we're depressed. Academics suffer. We talked about the emotional problems. Again, we begin to engage in poor eating habits, and that could be overeating or not eating enough. And then we also then sometimes begin to engage in unhealthy kind of coping habits or lifestyle practices because we're stressed out. And so specifically as it relates to students and learning, when they're stressed, their concentration is impacted, their motivation is decreased. So, being able to get motivated to do an assignment or even get to class can be really hard. They struggle with memory, they're forgetful, they can't focus or attend. Organizing becomes really a challenge, which is really important when you're in college, to be able to organize your day, organize your classes, organize your assignments, prioritize what needs to be done and be able to execute. This really suffers when people are stressed out. And then again, back to the emotional problems. And so I've kind of outlined super fast, how we got here and what's going on. But we can do better, and we need to do better. And so how do we begin to think about creating a culture of health and well-being? And how do we begin to think about equipping students, caregivers, faculty, and staff with the education that they need and the tools that they need to support themselves and to support other students who are in need? And so again, this is just really a recap of the fact that anxiety, depression, suicidality, and loneliness is increasing. And while mental illness is impacting all races, kids of color are less likely to get treatment. Faculty and staff are overwhelmed. Counseling centers are overwhelmed. Wait times are long. Some schools maybe will have just limited sessions. Maybe you can see someone for 5 or 6 sessions, and counselors are burnt out. And so this is really complicated, and it's really going to take us being creative and thoughtful, because a cookie cutter approach is not going to work. But we need to really begin to think about how do we increase awareness, increase education, because I think that's the foundation, but also, again, providing resources and services, and what good are services if they can't access them. So really making sure we make services that are accessible to our students, and thinking about what other ways can we go about supporting. And just really, I'm going to get on my soapbox. Education is so vital, because without education, we don't know what to do. We don't know what we're looking for. We can't engage in preventative measures. We can't engage in early intervention measures. And if we are knowledgeable and we have education, we can begin to have this platform to create conversations and dialogue, kind of like we're doing today. It gives us an opportunity to work on dispelling the myths and the misconceptions, and really whittling away at the stigma that is so huge still, and so many amongst so many with respect to mental illness. But also, education allows us to begin to be able to be resilient and change perspectives. And so I think education is so vitally important. But again, when we think about how do we begin to prevent and identify illnesses early, this has the best outcomes in all of medicine. And so that's really, I think it starts with education. Everyone needs to know 3 Ws, and everyone from students, again, caregivers, staff, and faculty need to know what to look for, when to worry, and what to do. And specifically, what to look for. This is a short list, but looking, knowing what the signs of depression are, knowing what the signs of anxiety. I hear so often students will say, or parents will say, I didn't know this was anxiety, or I didn't know what I was experiencing was depression. And so it's so important for people to know the signs and symptoms. And so when I start to sleep poorly, or when I start to struggle with my emotional regulation, or when I start to engage in risky behaviors, these are all things that should be warnings or red flags. Especially if you start to have dangerous ideas or suicidal ideation. When do you need to worry? Well, when there's a major change in your personality or your behavior, when you start noticing that your performance is declining, you stop going to class, you stop hanging out with people. If this has lasted a long time and there's no signs that things are letting up, this is really when we should be concerned and we should start to worry. And any of these other symptoms that we talked about. And what do you do? And so, again, there are things that we can do from a preventative standpoint, like engage in self-care, start to really work on building resilience. If you are trying to support someone, like how do you ask about their struggles and challenges? How do you listen and validate? But we want everyone to know, whether you're suffering or whether you're a support person, you don't have to worry alone, and there are resources for you. And sometimes, that could be enough, but maybe things maybe have gotten to a point where you need to seek professional help. And so these are, again, really important things that everyone really needs to know, kind of like the back of their hand. We talk about this in all of medicine and other we talk about it as it relates to diabetes and hypertension. We need to talk about it in the same way as it relates to mental health. The other thing that I think is really important for us to think about as we were thinking about how do we address the challenges is how do we do a better job of incorporating parents and caregivers, and how do we provide education to parents and caregivers. And I'm really focused on parents and caregivers because, you know, so often kids just yesterday before they went to school were living at home, you know, among a family requiring support and guidance. And parents really need to be equipped with the tools and strategies and education to learn how to support their child from afar. And afar could be, you know, down the street or across the country, but really, you know, it's a balancing act. We really are trying to definitely encourage individuation and adulting. And we also know that, you know, this is a process and we can't expect because the page on the book is turned that they're going to automatically get it. And so really thinking about how we can creatively incorporate parents and provide them the education. This really has to happen before they get to college. You know, I sit down with my parents and we have a meeting and we talk about all of the things that I want them to do before they get to school in terms of whether it's figuring out what the resources are on campuses, how do you access them, where's the pharmacy that's closest to you. There's a list of things that we can begin to talk about before they even get to school. And I think there's so many opportunities for schools to engage parents. And so whether that is when they come for tours, if they're just exploring schools, when they come for orientation, when they come back for the first day of school, when they come for parent week or weekend, there's so many opportunities to engage parents. I think we need to think about this in a way that is, again, not hindering the adulting process, but also not ignoring the fact that that we are not living on islands unto ourselves. And most students have families or someone that cares about them that can be supportive. I say parents again, but I also think that thinking about this from the standpoint of supporting and educating faculty and staff is really important because often we hear from faculty that they often hear first that the student is struggling. The student might come to them sharing some concerns or that they're having, and faculty and staff also need to know what to do with this information. They might notice a student isn't coming or suddenly a student is sleeping in class where they didn't before. And so again, everyone needs to be aware. This is really an all hands on deck situation. And lastly, resources and services. I'm not going to get into it because I think my colleagues can do a better job than I can, but really just thinking about how do we promote and make awareness about the resources and services that are available. Again, often students will say, I didn't know, I don't know how to access, I don't know who to call. Making sure the resources and services are user friendly, meaning that they're friendly to college students. Thinking about how we can increase diversity among providers, whether it's gender, ethnicity, race, culture, and thinking about how we can approach this from a standpoint of cultural humility. And lastly, thinking about how we can lean into peer support and peer groups, because sometimes students maybe feel more comfortable going to someone that maybe looks like them or has had a closer from a timeline standpoint in terms of their experience. And so with that, I will just leave you that we don't have any time to waste. Mental illness is disruptive, it can be life-threatening, and we could do a better job around supporting our young people.
Bravo, Dr. Booth Watkins. Okay, Dr. Campbell Foster, over to you.
Thank you very much. It's a pleasure to be here today. I am here as the Dean of Students at Boston University, and I'm speaking to you all today primarily from a non-clinical standpoint. I oversee many of the student affairs functions, not including the counseling center at Boston University. And so I'm here to represent those of us who, like Dr. Booth Watkins shared, have a responsibility to center the learning and education regarding this topic and to elevate students as they, essentially go through some of these very significant transitions in their life. I think it's the important piece first is to understand the context of your university. You know, we can certainly go through and have discussions on best practices and what some of the research is telling us about priorities regarding mental health of college students, but it is imperative that our approach takes into account who we are as an institution. And the best way to do that is really to directly engage with your students on this campus and pull out some themes that are germane specifically to that community. There may not be anomalies from what you see in best practice, but there may be some very unique characteristics of your student and your climate that can be addressed through various intervention techniques. Adopting a scholar practitioner model has been a way that we have been incredibly successful at scaffolding non-clinical support for our students and to boost their mental health and sense of well-being. So relying on what is there in the research, but also a practical on-the-ground experience and response program is also incredibly important. So as the previous speaker mentioned, there are a variety of challenges that our students are facing on college campuses today. And these 6 that I've chosen are the ones that tend to come up most often in our conversations with students. Academic performance is one that is increasingly becoming more of a consideration among college students. I refer to it as the elusive A. Students who were able to achieve A's in high school very easily or relatively easily are coming into college campuses and realizing that the A is not so easy to achieve. They are incredibly competitive. They are taking note of what others are doing to succeed and are, of course, putting a great deal of pressure on themselves to continue to perform above average. And this, of course, requires an incredible amount of attention to the academics of an institution. So an increased focus on academic performance essentially results in less time spent on the co-curricular experiences that bring you a sense of well-being, that bring you a sense of calm and connection with peers and with folks who are within communities. And so it does create a distraction from the robustness of a college campus and all the other offerings that are available to alleviate some of the stressors that they experience. As Dr. Booth Watkins shared, underlying conditions as more and more students, and I do see this as a good thing, are coming into college with an understanding of who they are and what a diagnosis might be that they're bringing with them to the university. And so some of these conditions are already in place and can be impactful or can be exacerbated by the additional challenges added in a college setting. So it's really important when you're working with students to the extent that you can to try to understand the big picture of what it is they're experiencing and why they're experiencing that, as it may change some of the mitigation or intervention techniques that you employ. More and more financial pressures are on our students as the cost of college tuition arises. Some of what we're seeing is an inability for students to meet their basic needs, such as food, housing, textbooks, tuitions. And this adds, of course, to the pressure they feel to earn additional money, to try to seek out additional scholarships, to take on extra jobs. And this pulls, again, from their sense of well-being on a campus as they're fighting in some cases to stay enrolled at universities. As we undertake a very valiant effort to enroll more first-generation college students, more Pell eligible students, this becomes more of a piece of what we need to focus on, is how to build scaffolding around students so that other aspects of the college experience, such as housing, such as food, can be attainable while they're here. There are also students that are working and providing for their families. Many of them are taking leaves of absences to take care of parents and family at home, returning to the university and trying to continue with their studies. And of course, this can add additional anxiety and pressure to their performance anxiety and, of course, their sense of belonging on a college campus. One area that becomes typically can be fraught with some of our students, of course, is relationships. Mental health is deeply impacted by the relationships that our students have, not just with their peers, but with faculty and staff. And as we know, college is an opportunity to navigate complex relationships, overcome conflict, negotiate relationships with adults and family at home as your worldview changes and your personal values may evolve and deviate from what you were taught as a young child. There's a lot of reconciliation going on with conflict, and there's a need for students to feel as though they can solve these conflicts on their own. But in a college setting, as we know, we encourage independence and the building of skills to allow students to solve their own complexities. And of course, coming from a high school setting where mom and dad or grandma and grandpa were closely involved in resolving these conflicts for you can result in a skill gap that universities need to fill. And transitions and adjustment are another frequent conversation in this landscape that we have. You know, attending college is a significant transition in and of itself, but there are a series of transitions throughout the 4 years, going from a first year to a second year, leaving to do an internship or a summer work experience, returning to the university, going on a leave of absence and coming back, as I mentioned earlier. All of these transitions, while some can be energizing, others can be very, very daunting. And so so it's essential that we keep mind of how we support students during these times. Geopolitical stress has been one, certainly since October 7th, that we are seeing more of. Is students are connecting their identities inextricably to what is going on in other areas of the world, and they're worrying about friends and family at home. They have anxiety about what's happening here in the Supreme Court in the United States. They are closely watching the world that they're about to enter and are working very hard to reconcile that and to create change really within their local communities. And this does add a sense of pressure for our students. There is a concern about having dialogue at times, whether or not the universities and peers will be affirming to their identities or their positions and ideologies. And so we've got to create safe and comfortable environments where students can engage across difference. And so some of the mitigation strategies, I think this is where folks outside of a counseling center can partner very closely with folks in the counseling center to deliver student well-being and skills. First would be, increasing awareness and reducing the stigma, promoting open conversations about mental health, encouraging students to seek help without judgment or shame, educating the college community on available resources, elevating the conversation so that it is commonplace and that there is no shame associated with asking for help. Sustaining a supportive campus environment. This is a multifold and multi-tiered effort, which can include developing inclusive policies and practices, prioritizing student well-being and campus activities, offering opportunities for social connections and community building, making resources available centrally to our students. I think at a large institution, it can be difficult to advertise all that there is to offer in terms of support networks for our students. So coming together cross-institutionally to developing a central catalog of resources can be incredibly helpful for a student who is struggling to find, to not only see the robustness of your services, but find specifically what it is that they need. Centering self-care, educating students on techniques for taking care of themselves, finding psychological safety, encouraging breaks from social media, which can really perpetuate toxicity and cause students to not feel terribly present. And promoting physical activity and mindfulness, yoga, meditation, pauses and study breaks so that you can be together and experience joy with one another. These are important elements of what student affairs folks such as myself need to build into the university experiences at key times throughout the academic year. Collaborating with professionals is key for student affairs. As I mentioned before, I do not oversee the counseling center, but our partnership with mental health services on our campus really does contribute to the holistic sense of well-being and the shared responsibility that everyone at the institution has for cultivating an environment that supports student thriving. Training faculty and staff to recognize the support for mental health, as the previous speaker mentioned, highlighting to folks who work with students in all capacities on a campus, what are some of the signs they should look for? What are some ways that they can begin a conversation and try to approach a student who may be struggling and to offer a sense of care and support for them? These strategies and teaching folks how to employ them are incredibly important. And partnering with external organizations to enrich conversations pertaining to mental health. Being in the city of Boston, we are particularly lucky to have access to a variety of healthcare organizations in the area that take into account the diversity of students on our college campus and provide targeted services that can be added in addition to what is offered on campus. Being aware of where you are, the power of place is incredibly important. Empowering peer support networks, I think, is one that we have seen a great deal of success with. This is training student leaders, peer-to-peer support on mental health awareness and self-care, carving out time for student leaders to look out for and take care of those who are part of their student organization and refer them to campus services is critically important. Creating safe spaces for students to connect and share these experiences, talk about how they're feeling, talk about how their identity impacts their well-being, what's happening geopolitically, how it impacts their lives as a student and a human. And these are really important opportunities for students to feel as though there's not a sense of isolation around these issues, that they are prevalent and that students can find a sense of connection through this. And of course, building personal capacity, as I mentioned earlier about some of the financial considerations. offering workshops to skill students up on financial independence, what it means to have good personal budgeting, talking about ways to find resilience, support for student activists who give a great deal of their time outside of the classroom to stand for causes that are dear to them. How can we be there for students through their multiple hats that they wear at a university to build their capacity? I always think very intently on, I have a 4-year window, a 4 to 5 year window when I can build a safety net for our students. What can I do in those 4 years to educate them for a lifetime of being able to meet their goals, to exceed in their life, and to have the skills that they need to weather any future storms? And so what has been our guiding principle, or my guiding principle, is developing services where everyone feels seen, heard, and served. And that is incredibly difficult at an institution that is large, where the needs are vast. But I hope that through partnership and through peer accountability and support, it is possible to build a network of students, faculty, and staff who are devoted to the mental health success of our students. And I look forward to answering any questions that you might have shortly. Thank you.
Thank you, Dr. Campbell Foster. We'll now turn things over to Dr. Schofield.
Thank you, Dr. Campbell Foster. Let me go ahead and share my screen. Okay, hopefully my slides are coming up. Yep. So it's really a pleasure to be here to speak with you about our work at the Center for Collegiate Mental Health at Penn State University. I'm Dr. Brett Schofield. I'm the Executive Director of the Center for Collegiate Mental Health, otherwise known as CCMH. And just a bit about what CCMH does. We're a national research center, and specifically, we're a practice research network that looks at collegiate mental health. And specifically, we focus on the subset of the college student population who are seeking college counseling center services nationally. So our data that we have are on that subset of students who are in clinical care. It's not a general student body survey, and it's not the general student population. It's those students who are seeking services. We were founded in 2004, and we collect data from, de-identify data from students who are in services, the therapists who are treating them, the centers where they are treated, and the institutions in which they are enrolled in. And our network has grown to, we have, this past year, we had 775 plus counseling centers as part of our network. There are 7,500 clinicians who benefited from our tools that we provide. And we had over 660,000 students in treatment nationally who benefited from our research and our tools that we provide. Our relationship with our members is bidirectional. So we get information from them in order to advocate for mental health services. And they in turn use that information we provide to inform care and the tools that they provide that improve services to students nationally. All the data that I'm going to show you in the following slides is updated from our most recent findings, and it's going to be published in an annual report next month in January. And again, this is all data from the subset of students who are receiving clinical care nationally. One of the questions is what's changing in the population of students who are seeking care. And as you can see, in the past 13 years, depression, generalized anxiety, social anxiety have all risen pretty substantially, or in the past 13 years. And I'd like to point out a couple of more recent trends, is that academic distress, eating concerns, family distress, and social anxiety are all areas of distress where students self-report that has increased a bit since the onset of COVID. And I'd like to point out that only of those areas of distress, only academic-oriented distress has been declining since that initial year of COVID. You can see here during that remote year of instruction that students' academic distress, that is, academic distress is problems of motivation, concentration, and completing schoolwork on time. That is the only one that's receding. Out of all these areas of self-reported distress, though, social anxiety is the one that has increased the most in the past 13 years. It's gone, students 13 years ago, about 26% of students nationally came in with elevated social anxiety. Now it's about 37%. The symptom of social anxiety that's changing the most is concerns that others do not like me. So it's that social comparison process, potentially fueled by social media. The other area of distress the other area of mental health that we need to be particularly aware of in terms of students seeking care is the rise in general experiences of trauma. You can see all areas of trauma are increasing in the last 11 years, which is general experiences of trauma have gone from about 31% of students nationally reporting this 11 years ago to about 47% are experiencing some history of trauma. We delved into this closer to see what specific traumatic events are accounting for this rise. And there's two that really stand out to us. It's childhood emotional abuse and sexual violence. Those are the two specific areas of traumatic events that have been increasing in the last 11 years. So this really speaks to us as something that needs to be on our radar in terms of what we're working with students in care nationally, but also in the general student population. Again, social anxiety and history of trauma are the two that are increasing the most. One of the questions we get quite frequently is what's happening with the landscape of collegiate mental health nationally over the last 10 years. And the narrative really is crisis oriented in that there's a lot of students who need services and the supply of services available to treat those students is just not able to accommodate that. And we've been able to track what has actually happened in the last 10 years that might account for that. So in 2015, we really showed that there was rising demand for care. And that was happening for the past 2 decades, where there's more students who are asking for services nationally. We think that there's a couple reasons for that. One is that our efforts to destigmatize services have actually been successful. There still is stigmatization of services, but we've been very successful at having students feel more comfortable asking for care. We've been able to identify students who are in need. And I also think the K through 12 system has also done a very good job of supporting students and having them more comfortable with transitioning into care when they're in college. But when you have rising demand for services without concurrent focus on the supply of treatment in order to accommodate that demand, counseling centers can get overwhelmed with services, with being able to treat that many students. And then what you see is that clinical models and counseling centers shift. So instead of being able to provide routine treatment to a large subset of students, is that we have to shift our models a bit. So we have to focus on crisis, or we have to focus on what was called rapid access services, which is getting in as many students as possible to assess them and get their short-term needs met. And then when clinical models have to shift and you see more people in the short-term nature, counselor caseloads rise. So counselors are responsible for more people across the year. And when counselors have higher caseloads, generally the outcome is that students receive less care and students have poorer outcomes in treatment. One of the areas that we focused on this year was on students' experiences of identity-based discrimination. And a bit on the history on this is that on May 25th, 2020, was when the murder of George Floyd occurred. And it really made us look internally at what kind of data are we collecting within the Center for Collegiate Mental Health about students' experiences of identity-based discrimination. And up until this point, all we had was whether a therapist indicated if a student came in with some kind of discrimination-related concern. But our thinking was, what if we asked students when they enter services about their experiences of discrimination in the prior 6 months before entering care? So in July 1st, 2021, we implemented this question that asked about discrimination or unfair treatment based on any of these 6 identities. And about what we found across a 2-year period is about 20% of students nationally report some area of identity-based discrimination in the past 6 months. And one of our questions was, if students experience discrimination, does it correlate with distress? And I want to be clear that discrimination, identity-based discrimination, is not a mental health concern. It's a societal problem that needs to be addressed. And we wanted to explore, does it correlate with distress? And you can see from the figure here it's an emphatic yes. Students who have one area of discrimination or multiple areas of discrimination are significantly more likely to present to counseling as more isolated, more suicidal ideation, and more distressed across the board. So we know that students who come in with identity-based discrimination are more distressed, isolated, and suicidal. The second area that we wanted to explore, when students receive services who have experiences of discrimination compared to those that don't, do they change during services? Do they improve? And we looked at these three variables. Do they get better in general distress? Do they get better in feeling less socially isolated and experiencing less suicidal ideation? The green bar is the change and from the beginning to end of treatment for those with discrimination. The gray bar is the change for students with no discrimination. And as you can see, people with discrimination change at about the same pace as those students who do not experience discrimination. And this shows us that counseling centers are very effective at supporting students with these discriminatory experiences. Even more so in some cases students change at a greater rate than people without discrimination. But as you can see here, one of the concerns we have is that there's an outcome gap, is that even though counseling centers are effective at treating these students, there is students who have discrimination in treatment at much higher rates of distress across the board than students without discrimination. And this points to a picture of the counseling services are only part of the picture to support these students. Students who experience discrimination need additional support services. And our report really emphasizes that DEIB efforts are more needed now than ever to change these improvement gaps that we see in students who have discrimination experiences. So our report really just underscores the need for cultural centers and strong DEIB efforts across the board in order to support these students, in addition to the counseling services. Just switching gears here for a minute, looking at the big picture. And I was thinking about some of the content shared by Dr. Campbell Foster and Dr. Booth Watkins, is that this is what generally colleges and universities are doing right now to try to provide holistic support for student wellness and mental health concerns. So in public health, we all know that there's 3 layers of prevention. There's primary prevention, there's secondary prevention, and there's tertiary prevention. Well, what colleges and universities are generally doing is trying to have coverage across these different areas. Primary prevention being where you target a problem before it becomes an issue, before it actually arises. And institutional wellness efforts, peer support programs are all being put in place to do that. Secondary prevention are those subset of students who have early onset of symptoms or early onset of problems. We have Let's Talk programs, which are brief consultation programs, generally provided by the counseling center, self-help platforms, coaching services. And tertiary care is that clinical care generally provided by the counseling center, and that is individual group therapy, crisis services, and teleservices. Downstream and upstream are 2 terms you hear right now in higher ed to describe what we're doing to try to intervene and provide wellness support to students. Downstream is where your emphasis is when a student you have concerns about a student, you push them downstream to tertiary care services. So you push most of your referrals to treatment. What we have found is that especially if your counseling center has higher caseloads than average, is that if your efforts at colleges or universities are more downstream focused, you can have a tendency of maybe overwhelming counseling center staff. What we're trying right now in higher ed is to try to focus upstream and even midstream, where we focus efforts more beyond the counseling center to secondary prevention and primary prevention efforts in order to provide students with multiple options in order to seek services. We do know that there are mental health concerns that students frequently have, and not everybody needs a mental health intervention by a licensed clinician in order to support them. There's academic support services, peer support, general wellness programs, and other areas that we can support students. And I think, again, Dr. Campbell Foster and Dr. Booth Watkins really highlighted those well. This is the conclusion of my portion of the presentation, and I'm going to turn it over to our next speaker.
All right. Thank you so much, Dr. Schofield. Our next speaker is Dr. Joe.
Hi, everyone. Thank you, Dr. Schofield, for that great presentation, and everyone in the audience for joining this afternoon. So I'm going to be talking about mental health in U.S. higher education, specifically some trends in the national landscape, which will echo the data that's already been shared by some of our great presenters today. And I will also discuss a project that centers on disparities that we see related to Asian American, Pacific Islander, LGBTQ+ mental health. So the work that I'm going to be talking about today draws from data collected in the Healthy Mind study. So I know Dr. Booth Watkins had mentioned this earlier. The Healthy Mind study is an annual online survey of mental health, help seeking, and related issues among undergraduate and graduate students. And it's currently the largest and most comprehensive survey of mental health on campus. Our team actually spans 4 institutions, and I wanted to give a shout out to my amazing colleagues in the Healthy Mind Network, some of who are joining today and who I'm very lucky to work with. Our leadership team includes Dr. Sarah Lipson, who is at BU and helped organize this panel, Dr. Daniel Eisenberg, who is faculty in the Department of Health Policy and Management at UCLA and the founder of our Healthy Minds Network. And last but not least, I want to recognize Dr. Justin Hines, who is leading our team located at the University of Michigan. So a little bit more about Healthy Minds. The survey was established in 2007, and we now have over 700 colleges and universities and about 250,000 or 750,000 student respondents in our sample. We get random samples of students from each school, with smaller schools choosing to field their survey to their entire population. And one of the unique aspects of this survey is that it uses clinically validated mental health screening tools. So we're actually administering some of the same screening tools that would be taken in a healthcare setting for formal diagnoses. And this would include the PHQ-9 to measure depression, the GAD-7 to measure anxiety, as well as the SCOFF-5 questionnaire to measure the presence of eating disorders. And what we found in the last decade or so in our data, which mirrors some of the other studies on student mental health, including the National College Health Assessment data, is that mental health symptoms have been on the rise. So for example, in 2014, we see that just under 10% of students reported seriously contemplating suicide. And in 2022, we found that suicidal ideation has risen to 15%. And we found similar upward trends when we're looking at anxiety and depression across this time period. I think Dr. Schofield also talked about that in the CCMH data. And I think what's really important to show here is that we're seeing this continuation of a very troubling trend as opposed to a unique spike that came out of nowhere with the pandemic. So this trend line was already going up, and the prevalence was already high before COVID-19 came into the picture. So in parallel with increasing rates of mental health symptoms, we're also seeing from the data that in the last decade, students have also significantly increased use of mental health services, including past year therapy and counseling. But in spite of this upward trend, there's still a significant amount of unmet need in terms of treatment for mental health. So this graph is actually taken from a paper that we authored as a Healthy Minds team, which was led by Dr. Sarah Lipson, where we looked at trends in mental health and help seeking across race and ethnicity from 2013 to spring of 2021. And this graph really depicts the proportion of students who have clinically significant mental health symptoms who were receiving therapy in the last year. And we see that across the board, therapy and counseling among students of color with mental health symptoms is significantly lower than compared with mental health treatment use of white students with symptoms. But there are some groups that stand out. And we found that in our paper, since 2013, while the rates of therapy has on a whole increased for all groups, Asian Pacific Islander, Daisy American students have remained among the lowest or the lowest utilizers of mental health treatment across racial and ethnic minority students. So in light of this, I wanted to highlight some specifics on Asian American Pacific Islander mental health. So the proportion of AAPI students on campus has been growing steadily. And right now, AAPI represent about 10% of enrolled students in post-secondary education, with some campuses ranging all the way up to 40%. And even pre-pandemic, we found that AAPI college students were a high-risk group to really consider when thinking about mental health. So AAPI young and emerging adults tend to underutilize psychological services. They tend to have more negative help-seeking attitude towards mental health services. And in a study that I had co-authored with Dr. Janelle Goodwill at University of Chicago, we found that Asian international students actually had the highest odds of suicide attempt out of all racial and ethnic groups that we studied. And all of this is just really to underscore that AAPI students have found to have high levels of unmet need when it comes to mental health support, and related to this, a high prevalence of suicidality, and are also often overlooked in conversations about mental health. So the trends that I just discussed are what motivated many of the projects that I've taken on. And to give you a glimpse of this, I want to discuss some findings on a project focused on AAPI LGBTQ+ college student mental health. And I wanted to acknowledge my colleague, Dr. Christopher Stojanovsky at Tulane, who collaborated with me on this project. So right now, there is a considerable body of literature that has found strong associations between sexual orientation and gender identity and elevated rates of mental health symptoms. But intersectional mental health work on this population kind of related to the impact of multiple layers of discrimination and victimization among sexual and gender minorities of color. So these studies are more scarce. The Trevor Project did release a report in 2021 on AAPI LGBTQ+ youth, which gave an excellent summary of the mental health challenges in younger populations during the peak of the pandemic. And so our project takes a different age population and focused on describing the national landscape and assessing associated risk factors of AAPI LGBTQ+ college and university student mental health using our Healthy Minds data from 2021 to 2022 that was collected across 133 college campuses. And this is some of the preliminary findings from our work. So among AAPI LGBTQ+ students, nearly 60% reported symptoms of depression, and nearly 80%, 79.1%, reported symptoms of at least one clinically significant mental health condition. And this includes anxiety, eating disorder, non-suicidal self-injury, or suicidal ideation. And in this slide, I am showing you the treatment gap, which is the proportion of students who have clinically significant symptoms who were not receiving any form of treatment. And we define treatment here as receiving counseling, therapy, or psychotropic medication among students with mental health symptoms. So among AAPI LGBTQ+ students with depression, we're seeing about a 42% treatment gap. And for students who report seriously considering suicide, we're seeing about a 35% treatment gap. And while we don't necessarily ever expect to see the treatment gap to be zero, it's still really important to consider the implications of this relatively high treatment gap, as nearly 43%, if you've seen this last bar, 43% of AAPI LGBTQ+ university and college students with mental health symptoms are not being currently connected with any type of formal treatment services. So next, I'm showing here the findings of our multivariate model on the correlates of mental health symptoms among AAPI LGBTQ+ students. And some major takeaways really include, those who report sense of belonging had lower odds of mental health symptoms. Resiliency and exercise of more than 1 hour per week were also strong protective factors for mental health. And in terms of risk factors for mental health symptoms, those who report current financial stress had 2.3 times greater odds of mental health symptoms compared to those who did not. And then this slide highlights kind of the correlates of mental health treatment among students with mental health symptoms. So those who reported experiencing discrimination, older students were more likely to receive treatment, while those who reported financial stress and higher resiliency scores were less likely to receive treatment. So that was a very quick overview of the project. But in summary, AAPI LGBTQ+ students are this unique group of young people that are vulnerable to mental health challenges, which we know from the literature can really negatively impact academic performance and cause physical health complications and so on. And the Healthy Mind Study is going to continue to collect data on AAPI mental health and other minoritized populations. And we actually have some really interesting projects in the works related to racial trauma and discrimination in campus climate. And our project also highlighted, similar to the general young and emerging adult population, that structural drivers such as financial insecurity is associated with poor mental health. And it underscores really this need to consider the adequacy of current approaches in supporting AAPI LGBTQ mental health. And really highlighting the need to invest in both culturally responsive and LGBTQ+ affirming treatment and prevention programs. One thing that I also wanted to bring up is that AAPIs are the most understudied racial and ethnic groups in peer-reviewed literature. So less than 1% of the NIH research budget over the past 2 decades actually supported Asian American health research as a whole. So it is really important to continue supporting research in this space and using data to regularly assess population level needs and priorities and progress. And there's definitely a lot more work to be done in this space in the future. So thank you all for listening.
Thank you so much, Dr. Zhou, and thank you to all of our speakers for their presentations. We will now move on to our moderated discussion with all of our speakers. So if you could please turn all your cameras on, that would be great. As a reminder, we will turn to audience questions when there are about 20 minutes left of the program, which is in like 12 minutes. So we'll just do a few questions here and then turn to audience questions. Please, if you still have a question, submit it through the Zoom's Q&A function at the bottom of the screen instead of the chat. So we'll get started. And I'm gonna call on people, but then anyone should feel free to jump in, but that'll just make it easier to make sure that we don't have a pause in when people are talking. So Dr. Campbell Foster, as Dean of Students at BU, you have a front row seat to the struggles and the successes of college students today. One conversation that has been mentioned here and that I know from a lot of student affairs professionals I've talked to is that loneliness poses great risks to mental health and physical health as well. And I think Dr. Booth Watkins talked about that a lot as well. So if you want to jump in too, that would be great. But Dr. Campbell Foster, could you talk about that and what efforts colleges are taking to combat it? Others should feel free to chime in as well.
No, it's a really important question. And I think, a sense of belonging on a college campus, as we've mentioned, is absolutely critical to the success and ability for students to thrive. And where I think it is important for us to think about is ways in which we can create individualized and customized support structures for students. Multiple touch points where students interact with faculty and staff who are caring, are empathetic, who are knowledgeable about how to make connections with students to opportunities that they may not have considered. And so accessibility of administrators becomes paramount in doing that. The amount of of students that I talk to who can't name one caring adult they can go to ask questions for is I think in a travesty. And so the more accessible we are to our students, the more comfortable they are coming to us and being vulnerable and asking questions, allows us to really combat some of the concerns of loneliness that we have. Coming out of the pandemic, of course, it has just exacerbated this sense of loneliness. And during the early stages of managing the pandemic, we had to operate on the very opposite of what my field of student affairs is committed to. We had to send folks to their corners to be alone, which is contrary to what we work towards every single day. And so the effects of that are still very much alive at a college campus, but ways that we can mitigate really are making sure that students have the ability to touch base with one person, whether that's a resident assistant, a member of the student affairs staff, a faculty member, somebody who's knowledgeable enough that they can trust and build a relationship with is key to helping them feel more connected.
Thanks so much. All right. Dr. Booth Watkins, you are an expert on the treatment of psychiatric disorders in children, adolescents, and adults. One development that holds a lot of promise for colleges today is telemental health. What considerations must colleges keep in mind when exploring the potential for telemental health services? Sorry, I messed up that question. What considerations must colleges keep in mind when exploring the potential for telemental health services to be used for medication management? I know that is an area that is still developing. So if you could talk a little bit about that, that would be great.
Thank you. Telehealth has really allowed us to expand our reach and see more people. It has definitely increased limited or decreased the no-show rate. So people show up more often to appointments because it's more convenient. You cut out the commute time. And so I think there is a lot of benefits to telehealth and really allowing us to really expand access. The things that I think that need to be thought about is sometimes there are things that we just need to do in person. And so if there are things like, blood pressure checks or, being able to see some nuances in body language and things like that, really, how do we convert a telehealth appointment and make sure that we still keep space for in-person appointments when they're needed? But we've done a really good job and have proven to do a really good job over the pandemic with the telehealth services. So I think that's the one thing to think about. Regulations may or may not change. We hope that the horse is out of the barn and they don't push it back in, but there may be some regulations that require people to be seen at some interval in person. And I think it's really just about thinking about how do you give the best care, and whether that is, I like to see people in person. I think people still do like to be seen in person, but I do appreciate the limitations. And so, whether it's we see you in person for the first assessment, and then we, figure out what interval makes sense in terms of best care, best practices along the way. Those are the things that I think that colleges need to think about. And then the other thing is, what happens when kids go home in terms of, and I think that's a big issue, they get all their care from school, and then when they go home for the summer, which is a long break, or when they go home for the winter, what happens to their care there? And then the regulations around limitations around prescribing and giving treatment across state lines have to be considered, and how do we support our students wholly? That's what comes to mind.
Mm-hmm. All right, thank you so much. Dr. Zhou, compared to a few years ago, the COVID lockdown and George Floyd protests, what is the state of mental health for underrepresented minority college students at large? Better or worse than that time period, or maybe just different? Are clinicians hearing students talk specifically about the end of affirmative action and the targeting of DEI programs by some legislators and policymakers? Tell us a little bit about how it compares to 3.5 years ago.
Yeah, I can tell you about my experience, our data from the Healthy Mind study, and also kind of anecdotally from what I've seen in my students and kind of students of colleagues as well. So the first part, I think I mentioned a little bit in the presentation, COVID really, it definitely had an impact on mental health. And I think some of the other speakers talked about loneliness and just kind of social isolation, but it really was what we've seen is just a continuation of increase in mental health symptoms. And, there's a lot of discussion on why we're seeing this. It's not kind of a unique COVID spike, but rather just a continuation of the existing issues that we've seen in college campuses. Many of the other speakers have talked about some sense of belonging, discrimination for, minoritized student populations. These are all issues that continue to impact the students' experience and well-being experience. One thing that I have seen in my students is the dialogue around mental health has changed, I think, since COVID. I think the younger generations, there is always an increase in comfort and decrease in stigma in talking about mental health. But I've noticed more and more students in my classes are comfortable talking about going to a therapist or the mental health supports that they know exist in the university, and sharing about, sharing the mental health supports that exist, and kind of normalizing what it means to seek care, outside of your friends and family. And I think that that's a great trend. I think I lost, I think you had multiple parts of your question, but I hope that answered some of it. Yeah,
that's great. Yeah, I was just the last part of the question was, are clinicians hearing students talk specifically about the end of affirmative action and the targeting of DEI programs by some legislatures?
I think that the students that I know, and I don't have clinical experience, but the discussions in my classrooms there's definitely a great awareness of the socio-political events happening. It comes up in almost all of my lectures. Students come to my office hours talking about them, and so I think that there is this real anxiety of what's happening in the world, and what can they do about it. And I think that that's definitely increased with this rise of TikTok and students constantly having, information in their faces all the time, nonstop, which is different than, even half a generation ago.
Yeah. So thanks so much for answering both of those questions. Dr. Schofield, I know you hold a leadership position in a counseling center, and through your work with CCMH are in constant conversation with other counseling center leaders. As we've talked about today, staff burnout and attrition have been huge issues over the last few years, especially as demand for counseling services increased during the pandemic. How have counseling centers been recovering from those losses? If there's any strategies you could share from your research, and what changes have they made to retain more staff?
Sure. Thank you for the question. One thing I just, aside from the question, I wanted to share too, that has been an impact of the pandemic that's not really talked about as much, that's more developmental, is that during that 2 years or year and a half where students were in significant periods of isolation, there are a lot of developmental milestones that were missed during that period. So when you're working with students now who are traditional age students, a lot of professionals are reporting that they're feeling like they're working with students who are developmentally younger than their chronological age supports. And part of that is because of the trauma and also the missed experiences of developmental milestones that happened during the pandemic. And sometimes students can't give voice to that in the moment, but it is something that we should be aware of, anybody who works closely with students. So in terms of the turnover and the staff burnout, what we have found is about, in the past few years, about 1 in 5 counseling center professionals leave, turnover in a year. So that's about 20% of counseling center staff leave. And that can be challenging to replenish. When you have clinicians leave, there's a loss of treatment, especially if it's during the year. There's a loss of treatment capacity. Students have to shift to different therapists. It can be disruptive to care. It can be disruptive to the impact on to the effectiveness of services. And also, it takes a lot of time to train new clinicians and turn over staff. So it's a cost to the university, the students, and the center. What we don't know is there's just a lot of nuance in this, because while counseling center staff turnover, we know that many professions had turnover in the past few years, especially in healthcare settings. And we do know that there's characteristics of counseling centers that are correlated with, we're not sure if it's turnover, but it's correlated with maybe more unhealthy practices or that can burn out counselors. For example, higher caseloads of counselors. When therapists might be responsible for more people across the year than they can potentially treat, that can be overwhelming. And it can cause them to make very challenging decisions for who do I see this week and who can I put off for 3 weeks from now. That's not generally what we've been trained to do as clinicians. We've been trained to kind of manage our schedules, but also see people for weekly, bi-weekly therapy. But sometimes caseloads get so high that they have to make difficult decisions about who they treat and when. And it can cause stress, burnout, et cetera. And also, especially if you're managing a caseload of high-risk clients. There can also be characteristics of counseling centers that where you overburdened the workload. So generally, it's called the International Accreditation of Counseling Centers, which is IACS. They have recommendations for a full-time counselor being 40 hours, what the caseload or what the clinical hours should be per week. And it should be about 24 to 26 clinical hours in a week, because there's other duties that therapists have. And what we do know is that there can be certain counseling centers that might be pressured to extend that to where counselors are doing more clinical work, which actually extends it beyond 40 hours and can lead to burnout. You really have to think about preservation of your staff. Last thing I'll say too is that there's still a smaller percentage of counseling centers, but it's still notable. I think it's like around 30%, where they're asking their counseling centers, in addition to daytime activities, that they're asking them to be also the 24-hour backup counselor if there's an emergency. Now, when you have a clinician that's working full-time during the day and seeing a full caseload, and then they're also doing crisis care at night, that's not really a best practice, because it can burn out the therapist, it can disrupt the center, and it also can affect the care that's provided to that student that's in crisis. Yeah.
Thanks so much. Okay, so we'll now move on to ask some questions from the audience. Kathy, I'm going to ask your question first. Kathy Coyne asks, what kind of resources should be in place to help university faculty identify and help students who are experiencing mental health concerns? She writes, many of my students have shared that they are dealing with anxiety, depression, or ADHD, which is helped me, sorry, I'll just move on to the next sentence. I'm sure there are many students who are not disclosing or who do not know what they are experiencing as anxiety. How can we help them?
I think it starts with knowing first of all, knowing what you're looking at and where most people aren't generally trained to know the signs and symptoms. So I think it starts with some professional development and education around just providing the basic information and tools. And then also, faculty and staff knowing the resources to send the students to, so knowing where to direct them. Like, we're not asking people to treat and engage in mental health care, but really, having some awareness as to, do I need to direct them towards crisis? Do I need to direct them towards something that maybe is just more peer support and maybe they're not there yet? What's available to them on campus? And so I think that at a core level could be really helpful. If you want to talk to them about other things, like if they're complaining about sleep, if you want to talk about sleep hygiene, like there's some basic things that I think anyone can talk about. But I think at the core, if you just want to be able to be like a mediator, you can just direct them to where they need to go in terms of services. That would be my thought.
A resource.
Thank you so much.
I was going to say a resource that's sometimes not taken advantage of as much. If a student is coming in with a mental health history and a formal diagnosis, and they're used to having maybe an IEP during their K through 12 system, is that there's disability resources offices that we can get students connected with that can provide accommodations if needed that support students in that classroom. There's a lot of students that have diagnoses coming in with those histories and aren't necessarily registered with the disability resources offices that can provide that support. That's something I think that faculty, staff, and students can become more aware of, and also faculty staff can help connect students to those services.
I also
Great.
wanted to jump in
Okay.
here and just comment very quickly that something that we've talked about as a team a lot is there's some low-hanging fruit for like faculty to include mental health resources on their syllabus. Like I found that many of my students just didn't even know that CAPS was free and that it wouldn't show up on their insurance statements. And there is still, you know, for some students, still a stigma in not wanting their parents to know that they are seeking mental health services. And then also our Healthy Minds team, we actually had we conducted a faculty and staff survey, and we found that, you know, like over 80% of faculty are actually having one-on-one conversations with students about mental health. So I just wanted to reiterate, you know, what Dr. Booth Watkins said is just providing more support for faculty too, and training to see kind of like this mental health first aid and how to recognize students in distress.
Great. Thank you so much. Thank you all. There are some questions related to current events. I'll just ask one of them now, but please, if you can see the questions, you could touch on the other points. One attendee asked, can you speak more on supporting the substantial numbers of students distressed as a result of the ongoing humanitarian crisis in Gaza and the ripple effects it has had on college campuses?
I think this is where we, specifically rely on our partnerships, right? So there are some students who will process what is happening in clinical settings. There are others who do not have clinicians that wish to elevate their voices through student organizations, and some who want to advocate for what they believe that the university needs to do to provide greater support to their specific identity group or community in general. And I think you need to have a multi-pronged approach to this. You need to have an awareness of what is going on, a sense of approachability among the student affairs staff and those that focus on student well-being so that they can speak to students directly. You need to have the ability to, at some point, circumvent what might be long-standing policies about how you obtain funding so that students can access organizational funds to provide programming in spaces of solidarity on their campus. It really relies a lot on our ability to pivot and to utilize all of our strengths. And also, again, relying certainly on faculty to be mindful of what is going on, to know who they can go to ask for advice if it comes out in their classroom, if they're dealing particularly with conflicts that they want support on how to handle and manage. It's providing skills to those who are directly in touch with students so that those spaces can be curated and affirmed as needed. But it does require the entire institution to come together from multiple vantage points to address what is going on. Certainly from a safety security standpoint, it's important that police departments are reviewing any threats, reviewing social media, content to determine whether or not any types of intervention is needed from a security standpoint. But it is also, I think, underscored that this is a time when, above all things, empathy and grace goes in a very, very long way to being a listening ear, to understanding the impact that it has on various communities, and to providing students with the opportunity to elevate the conversation in ways that they feel comfortable. That is, I think, from a student affairs standpoint, our main priority at this time.
I think another kind of just basic thing that people can do is really help students not to forget to take care of themselves, and really help them think about, as they are advocating or as they are, joining groups or whatever it is they're feeling that they're needing to do to support, themselves and their causes, making sure that they take care of themselves, making sure that they are, managing their social media, intake, managing their news intake, making sure they're still getting adequate sleep and eating well and just taking care of their basic needs. And so, that can happen. They don't need to go to a health center for that. They can have that conversation with a teacher or with a peer. And that's really why I think really making sure everyone has basic information. Because especially where it comes to social media, you may not be on social media to look for these things, but they find you. And so how do you recognize the signs and symptoms that your body is telling you that this has been too much, I need to take a break. And so I think some basic things like that can go a long way as well.
Great, thanks so much. Okay, I'm going to ask a question from Lisa Selmer. She writes that I'm an outpatient therapist who works primarily with young adults and college students. One of the most common issues I see are students who took a leave of absence or took a step back to focus on their mental health, who are now struggling to return to school. What can colleges do to better support the re-entry process? Brett or Khadija, if you want to answer that question, or anyone else.
I won't speak to the reentry process, but I think there's so much that can be done if we can prevent them from going home. And so if we can take the steps that we need to really identify things going poorly early, we can often catch them before the bottom comes out. And again, this is the conversation I have with my parents and the kids together before they go to school. These are the signs and symptoms that your child's not doing well. It may be that you set up a call every Sunday, and then on Sundays, they haven't shown up for the past 2 Sundays. Let's not wait and let this go on for 2, 3, 4 weeks. Let's get in front of it early. You know, how can we increase their services and their care while they're at school? The best thing that we can do is keep them there if it's safe, and try to bring care to them. And whether, you know, for some parents who have the capacity and resources, maybe we need to do a couple of more visits, maybe we need to have more phone calls, but how do we prevent them, if we can, from going home? Because the transition back to school is very difficult for many, many kids. So I will just leave it at that. And really that conversation has to happen before they get to school. How do you plan to support them from afar?
It's a really great question. I agree with Dr. Booth Watkins. We did a study. If you go back in time before they actually leave school, we did our 2022 annual report with the Center for Collegiate Mental Health, looked at dropout from school and what are risk factors for it and what are protective factors against it. So things that prevented students from dropping out of school during counseling were a couple of things. One, do they improve in symptoms, especially academic distress and depression and anxiety? If those things improved, students were less likely to leave school. That's a good sign. But the big thing also, if you think about belongingness, the added piece was involvement in an extracurricular activity. So if they felt they belonged, they were involved in an activity and were improving in symptoms, they were less likely to withdraw. But the reality is that there's going to be some of our students, due to safety issues, due to just critical symptoms, it could be external factors that they need to leave school. And I think it's really critical when they leave, and then when they re-enter, to have plans in place. So when they leave, I think it's really important to have a dialogue with somebody, whether that would be from the counseling office, it could be from the dean of students office, about what actually were the factors that led to this being, and I don't like to call it unsuccessful, because leaving could set them up for success in the future. So, but what led to this being a concern right now, or what led to this outcome? And it could be something related to the environment. It could be something related to the stressors of the school that they were experiencing. I think it's important to kind of pinpoint what it is that they struggled with. So when they go home, or when they take that leave of absence, those things can be worked on and addressed. A lot of times students might take a leave, but not necessarily work on the problems that might need to be addressed before they re-enter school. So we have students all the time who might need to leave, and we talk about, here's some plans or areas that work on, either with a therapist, with family, or whatever the support needs are, so you are better positioned when you return to be successful. When you return, I think it's important to have a dialogue with somebody immediately about return plan, about what is it that is to reinforce what supports might be needed up front for that student, or in place to start the semester, so it puts them on a path that makes them more likely to succeed.
Thank you so much for that answer. So the next question is from Krista Gloucester. She asks, in my work with students, what they continue to note as an issue in accessing mental health resources is time. I primarily work with graduate students, and their schedules do not allow them to have time to pursue mental health support or resources. Do you all have thoughts, resources, or examples on how student affairs practitioners and administrators can adjust schedules or embed time for students to get mental health support? Dr. Campbell Foster, if you'd like to start with that one.
Yeah, I think it's a great question, and part of what I hinted on in my presentation was that time management is a concern, and so I think it's really important that we think about the modes of delivery for this type of support. I'll give an example of one thing that Boston University has done is made the Headspace app available to students. So it is on the go. It is an available resource to them at a time when they have a moment carved out of their day and they want to just get centered, or they want to focus on something other than the noise that is distracting or putting pressure on them. It is an on-demand way of accessing services. And so in addition to, expanding hours for centers and creating call centers and emergency support, there's also a need for thinking through the on-demand services that we can provide.
Okay, so we'll ask another question. I think we have time for like one or two more questions, so let's see. We have a question. Those with greater needs might be those who use services the least because the effects of the mental health itself. How do you identify those students? Dr. Schofield or Dr. Watkins, if you'd like to start.
It's a team approach. It comes from, because sometimes when you're doing really poorly, you don't have the insight to really realize how bad you're doing. So it's a team approach. The parents or caregivers have to identify that this is not going well. The teacher or staff has to be able to identify that things are not going well, and this has been going on for quite some time. And so those people also being able to know what the resources are and how to get them connected to resources is really going to be important, because sometimes when you're depressed and you don't have motivation, you don't have the energy, you're not going to make it to the student center. And so is this a time where, again, we engage some of the mental health champions on campus? Like there are some other students or some senior students that can help, kind of not necessarily for the transportation part of it, but for just the support, get them to their appointment. So I think we do have to be creative and we have to be thoughtful. It's not going to be a one size fit all approach, but it's really hard when you're feeling so crummy to be able to take care of yourself, even though it's going to help. You just don't have the energy or the motivation to do it.
I agree. I think the earlier that we know a student might need more enhanced support needs during their collegiate career, the better off we will at making a successful experience for them. We're actually doing research right now at Penn State and at CCMH to try to better understand across the academic lifespan of a student, what are some risk factors that make students more or less successful just in the general student body that are mental health related. And when a student might have enhanced support needs that might not necessarily come across might not enter counseling services, what we do find is those students generally might reach out to other support services, maybe the faculty, other different offices that they might come to the attention of. And that's why it's critical to have, as Dr. Booth Watkins is saying, a team approach. Many colleges and universities have care teams or support teams that are available to address students, not just mental health, but what are their academic, social supports, what are their potentially needs, basic needs that they might have. And it's important that those teams have representation from all those different sectors of the college and university to help guide the student through whatever needs they might have in the moment. So I think I agree, teams of people that can work with students.
And just one more thing, I think, because sometimes it could be just the roommate who's noticing. And so really, like, I think about campaigns like Seize the Awkward and again, just basic information. We're not asking other students to treat each other or give counseling, but just to know how to have a conversation with your friend or your peer. And again, knowing what the resources are so you can direct them down the right path.
Great. Thank you to both of you for answering that. And thank you to all of our panelists for coming here today. I'm sorry that we weren't able to get to everyone's questions, but we're almost at time, so I'll wrap up our discussion. Thanks everyone who joined us today as well. It was an honor to moderate this discussion, and so I'll send it back to you, Dean Galea.
Thank you, Kate. Really, thank you, Professor Zhu, Schofield, Watkins, and Campbell Foster. It really was an outstanding conversation. I want to thank all our audience who participated, but mostly thank you to everybody for what they're doing. As somebody who has the responsibility for looking after a school, nothing is as important, more important for us than our well-being of our students. And to know that there is both the scholarship and practice that is trying to advance our thinking on this is immensely reassuring, and I think keeps us moving forward as the world evolves to create the best possible environment for students to thrive and grow. And it is thanks to the work of all of you that that's happening. So really, from the bottom of my heart, thank you. Thank you to our audience for everything that the audience does in this space. And I hope everybody has a restful break in the coming weeks. Everybody, take good care.
Thank you so much.